We'll go ahead and get started. So, for those I haven't met who are here listening on the call, my name's Mel Ebling. I'm a resident at the University of Cincinnati and one of the Rams board members at large. And so I'm really excited to be hosting this webinar for y'all today. Dr. Blomkalns has already sort of introduced herself a little bit, but I'm super excited to be chatting with her today as we talk about kind of the behind the scenes of academic emergency medicine. I don't think there's anyone better suited to answer some questions and give us some insight about what it actually looks like to work after residency in an academic environment. As she mentioned, she is the chair of emergency medicine at Stanford School of Medicine and was a previous president of the Society for Academic EM and current member of the Association for Academic Chairs in Emergency Medicine. So, without further ado, we'll go ahead and get started. The format for this is that we kind of have some questions and answers, like commonly asked questions that we'll go through. And then towards the end, we'll leave about 10 to 15 minutes as an open floor for anyone else who wants to tack on to what has already been discussed or has their own questions that they would like answered. So, without further ado, Dr. Blomkamp, would love to start out talking a little bit about the biggest differences in the day-to-day life between academic and community emergency medicine. Can you kind of give us the behind the scenes tasks that go behind differentiating those two roles for attendings?
Sure. So I'm going to talk fast because we have a lot to cover. So tell me if it's not working. So first of all, common myth that community physicians just have their shift and they go home and then that's it. In that situation, you might be assigned other tasks like QA or committee work or otherwise for which, and I'm speaking like to you as a community, it might be compensated or it might not be compensated. It might be part of your contract. Your particular compensation, and I'm drifting into other questions already, may be affected strictly by the number of RVUs you bring, in which case, obviously, in that situation, your interest would be doing things clinically. Often heard emergency medicine is shift work, and that's it. In some of those models, they expect you to take care of the patient until their end disposition. And sometimes that could leak over into things. And it's completely up to the group whether or not you're compensated for that or not. In academic medicine, there are portions for a faculty member. So they have a portion of what they do clinically, a portion of what they do for education, and then research, and then I would say administration and leadership. So and those portions can be either part of their compensation plan or not part of their compensation plan. And we get into some other nitty-gritty about clinical offload and so forth. So it's time spent mostly clinically with a few other things potentially sprinkled in versus clinical activity being part of your time.
Thank you. That was a really great overview. Going a little bit more into the compensation piece, you did touch on this quite a bit already, but for residents or students that are considering taking a job at a community site versus an academic one based on pay, is there really a big discrepancy between the two? Or again, as we consider clinical offload, how does that play into how those two groups of physicians are ultimately compensated?
So another common myth I'd like to dispel that community medicine is automatically a higher paid job. And in community medicine, you work as much as you want to work. If you want to work or you want to make more money, you can work 22 shifts or 30 shifts. I guess maybe not 30 shifts, but some huge number of shifts and you'll make more money. And usually there's the opportunity to do that because not hiring another individual is advantageous for the group. So that's generally part of it. But the compensation can be different. You need to know what their compensation structure is. And particularly in academic medicine, it could be very different and therefore salaries can be very different. I'd like to say that most institutions have gotten to emergency medicine to the upper AAMC levels for getting salary in emergency medicine, but even that might be a challenge because you don't know how the department has their revenue plan or their compensation plan, how they're allowed to execute it or what they're allowed to change. So I say to answer the specific question, they can be comparable. However, if the name of the game is compensation, strictly compensation, and you're not considering anything else in your life or burnout or anything else, the better bang for the buck is working in a community environment. But it depends. So
For sure. And I know that there can be definitely some regional variation with that as well. Thinking about I know the choice between community and academic can often start early when senior medical students are considering a residency program, whether they want to do more of a smaller community one or a big name academic institution. Do you have any advice for how one determines whether they're a better fit for academia and community practice and how you start considering that in med school?
Sure. So first of all, I want to say, you should leave all doors open and really think about what is going to sustain you for your career. Emergency medicine careers are hopefully long, and you go through different phases of your life, both personally and physiologically, that make things in your outlook different. So I think there has to be an attention to what you want to do ultimately and what will sustain you. And so to that part, if you're driven to take care of patients anywhere, anytime, anyhow, whatever, then that, community practice may sustain you. If you have the notion that you want to help people in rural areas, then I can imagine that clinical practice being very rewarding. Now, if you want to be on the cusp, the bleeding edge, where emergency medicine is innovated, defined, evolved, and so forth, or how, operations might be changed, or even how all of unscheduled care is changed, or forwarding the knowledge base in medicine or emergency medicine, then academic life has many advantages. I do want to say that I think most emergency physicians in both classifications reach what I call sort of like a second tier at some point in their mid-career, where they transition to something else. And I think it's worthwhile, even as a resident, thinking, well, what would be that something else? Because there's something about human physiology at the age of 50 that starts telling you, like, you probably shouldn't be doing a bunch of night shifts, and things are a lot more painful the next day when you're waking up from a busy shift. So it will happen. That's just, you could be saying, well, it'll never happen to me. It happens. It happens to everyone. So just consider that in terms of thinking what will sustain you over your entire career, not just for the first 5 years.
I think that's an excellent point. I'm at the age of 26 already experiencing that physiology switching in residency, so
Oh,
definitely noted. Uh,
yeah.
you touched a little bit on, for several individuals, sort of that shift either outside of clinical work or in different roles. Do you think that it's possible for someone later in their career that has a very academic background to switch over to the community pretty easily, or vice versa? Is it possible if we go the community route later in life, is it possible that if someone's driven by teaching or innovation later, that they can easily switch to an academic environment? What does that look like?
I'll start with your second part first. Virtually impossible. Very select situations and very select people who have very specific skills may be recruited back into the academic environment. Largely, folks who have stayed in the outside academic environment, they just get a little bit behind in terms of what's the latest and greatest and so forth, and sort of forgotten maybe how to effectively engage learners. And it's a real hard journey to get back. I won't say it's impossible to get back. The opposite is very possible, and that's often what happens in some second tier type situations. Whatever what I was talking about, like another career, they just want folks want to work clinically and focus on their clinical work. That can work if they've realized that you're not going to have residents anymore, and you might be like kicking it like during your shift and might have forgotten how much assistance perhaps you were getting before, and then suddenly all of it's on you, just you, and you need to sign the charts and figure out everything and see all the patients, whether they're 50 more or 5 more. It's a different mindset in terms of, and your employer is going to be looking for you to generate RVUs, and if you don't generate what you're bringing in, you won't last very long. So it's a much more market driven approach. But sure, I think that what I just mentioned was the only limitation that I would see. I remember when I made the transition from Cincinnati to UT Southwestern, and I was working predominantly at their university hospital. And it's when it first opened, it didn't have any residents. They were trying to make it would be strictly an attending run hospital. And I was like, whoa, I've gotta pull up my britches on this one, and realize that, you know, residents do offer a ton of help and backup. And if you're not working with residents, it's not easier per se, it's just very different.
For sure. And we'll kind of touch on this a little bit more, but to expand off of that, Both academic and community institutions do both tend to run off RVUs from the attending side. Is that considered for when you're seeing patients?
So this is where I think it's really important for residencies to talk about this a little bit and talk about compensation structures and how they can work. In short, it depends. So I'll start with academics a little bit first. So academics, the hospital makes a deal with the department or the School of Medicine in most cases as to how they are going to get revenue. So they could be based on collections from the hospital. They could be based strictly on the number of RVUs and use some kind of scale. In our situation, they pay us, regardless of insurance, regardless of collections, a certain amount of dollars per RVU. So there has to be a way to measure the amount of clinical work, and whether it's patient seen, nothing's perfect, right? Patient seen, RVU, complexity. Ideally, you can mash all that up and normalize for slow night shift, weekend shifts, or something that would work. But in general, the largest benchmark is, and I know it kind of has a bad word and so forth, but it just happens to be the name of the currency of the realm. Now, some departments just have a salaried model where people get that salary, regardless of how many RVUs they bring or grants or whatever, and how the department factors those things into a salary is up to them and up to the School of Medicine or the hospital. In some cases, the hospital and School of Medicine really direct what the salaries are going to be or how many attendings the department can have and so forth. In other models there, you can do as a chair what you want and do the best for your department. Just like in the community, they're going to have some kind of plan. And invariably, if they're trying to recruit you, they'll give you the mean salary or something like that. Ask for the median. This is not a normally distributed curve. The mean is going to include all the leaders of the group who make a ton more money, and then you're not going to see what the true average is. So, or average the way we think about it. Ask for the median and the mean. And I think you'll be surprised to see that there's going to be a fair amount of difference. Or in general, it's fine to ask about the compensation plan. But if they're on a salary type model, make sure you know what you're looking at.
You are hitting all the high points that I wish someone had told me earlier in my career, even though I'm just an intern. It was always kind of my understanding or the vibe that I got that RVU based compensation was more of a community thing. And then whenever you would look at academic jobs, it just had a salary posted, and you would think that given this appointment, that was just what you were compensated. So it's really interesting to hear that regardless of the environment, it sounds like there can always be a mixture of both. And that's something that definitely should be considered when
Right.
you're applying for jobs. And then we talked a little bit already about kind of switching back and forth between academic and community EM later in the career. And I know that this kind of goes into the structure of academic emergency medicine, and there's some different tracks that I've heard of. So I would love, and I'm sure especially for students and residents, would love to hear about what the actual hierarchy of academic emergency medicine, or really just academic medicine, looks like. How, like, what are the typical faculty ranks? What does that actually mean? Can you give us some insight on that?
Okay, so in a general university setting, you'll have the notion of professor, might have breakout professors with tenure or not, associate professor, assistant professor, and some places have the rank of clinical instructor. So those are the general ranks. Now, that's not the same or can't really be associated with chair, vice chair, assistant chair, associate chair, medical director, division chief, section chief, residency program director, education vice chair, and so forth. So I just read off a lot of examples of leadership in emergency medicine, starting with chair and, and in large point, there are all kinds of titles in between. I caution you on, it's so tempting to want to get a title when you're getting out. It's so tempting. Fight that. You'll get titles. All of you will get titles if you work hard eventually, and sooner probably than you really want. Don't look for that title. I would say try to dispel the notion that you need a title when you get out, because that I feel like comes along almost in a more natural way in the 2 to 3 year time mark when you've really settled in and you've shown your strengths and you know your aptitudes and so forth. Now, sometimes, the time's right and the place needs somebody with that title at that time, and you have to take advantage of it. But don't get lulled by the notion of a title. Did I answer the question? I think I got up on track a little bit.
For sure. I think knowing the different levels and how you sort of progress through them is definitely helpful. As you move up from maybe a clinical instructor or assistant professor role up to professor, does that automatically tend to come with protected time? And on just the notion of protected time in general, what is this FTE? How does it come about? Is this something that you start getting early on in your career as academic attending?
Okay, so wow. All right, let's start with clinical time, offload time. I prefer to phrase it as clinical offload as opposed to bought down time because not always is it bought down. It's sometimes just assigned. So for instance, a medical director of a site might have clinical offload to perform that medical direction. The hospital might offer some level of salary along with that, but often it's not what it is due. They might help along, but it's not really bought down. So think about it in terms of clinical offload. Every chair in every place has their own method for assigning clinical offload. And some of them are pretty transparent and out there, and some of them are not. And it's okay even if it's not, but just know that it differs across, and different chairs value different things. So when my people who I hire specifically for research, they're significantly offloaded in the beginning, but the expectation is within 5 years they have significant federal funding and can support their salary. So it starts with a gift, and then it comes back with later you have to give it back to me in some way to as we move up. So that's just one model. They could just give it, chairs can just give it to you. They can make you buy it down by what the hospital brings to you. It can be an arrangement for a period of time. It can be role-based because if you're a residency program director, you need to have something by according to the ACGME rules and so forth. So there are real differences in clinical offload, and I would highly advise in your interview not to mention it initially. I would advise that you want to work to come in, you want to contribute, you want to work as hard as it's necessary and demonstrate your value to the department. It's a real red flag to me and a lot of academic chairs if you bring up the notion of, well, how much clinical offload you're going to get. That's not what you want to start talking about, because life as a clinical chair, people are constantly tugging at my sleeve for more clinical offload, and it just brings you to a bad place. And so try to avoid that when you're talking in the interview. That could be part of the contractual arrangement or whatever, but don't bring that up in your first interview. You mentioned the promotion system a little bit from going promotion. So most medical schools, well, I shouldn't say all medical schools have that published and what they value and what they think is important. They're all roughly the same. It's contributions to the school, medicine, emergency medicine, and research. Now, keep in mind, this whole structure was developed before emergency medicine existed. So it was based on two basic things. One, how many referrals you brought in if you were a clinician, and how many grants you brought in if you were a researcher. And now we have combined folks, and it doesn't really work very well. And in particularly in emergency medicine, even though it seems like we have referrals, you can't individually as a human say, I, Mel Ebeling, I'm able to attract all the chest pain patients in the region of Greater Cincinnati. I mean, it doesn't work that way. So emergency medicine, this is tough. And I did a talk on this at SAEM last year that really get in and understand what the school values. So being in RAMS is huge. So putting yourself out there in national committee, national organizations, national academic things is great for upcoming promotion and even getting hired, but also upcoming promotion track and otherwise. If you can go through SAM and really contribute to a society or other societies, that bodes really well for promotion. Other than that, yes, it's going to be likely some publishing. Publishing is always, you've heard the term publish or perish. That's still a normal currency in the School of Medicine world. So people will say, well, you don't have to publish. You don't have to, but it'd be better if you did for your promotion, because it's really hard to distinguish yourself as a specialist in emergency medicine when we can't ourselves as individuals attract a certain type of patient. So we have to rely on some of the other measures to be able to build that portfolio.
That makes a lot of sense. And as a plug, as a Rams board member, if anyone is a medical student or resident on the call interested in getting involved in that, I'll drop my email at the end of the webinar and we can chat a little bit more about how to get you more involved. Speaking a little bit more on the academic track piece, the publisher parish, it's my understanding that nowadays, I don't know if it's a new concept or not, but it seems like for individuals that want to be in academic emergency medicine, there maybe are some more options in terms of promotion tracks and wanting to maybe be involved more so in the teaching realm and getting promoted from efforts on teaching versus people that are really into research. Maybe there's more of a research track. Can you sort of discuss the prevalence of tracks that are present at different institutions and how, if you're wanting to be in academic emergency medicine, how maybe you can pursue more teaching related scholarly activities versus research or vice versa?
Yeah, so thankfully, over the last decade, institutions have started to realize the value of what education brings and allowing the development of an education portfolio now as part of a promotion package. Most faculty, they do have the different rank, like sometimes clinical instructor or clinical researcher, and they have different names for different things. It really depends on different institutions. Pretty much here, if you do any clinical work, you're going to have clinician something as part of your title, or clinical assistant professor, in the clinical realm. So those vary between different universities. Yes, education is much more valued now than it is in the future. It depends on the different universities. Sometimes it can be credit within your institution and what you do inside the School of Medicine or within rotations or didactics within your department. For instance, ours does not include any of those things. You have to like develop curricula that other people use or do something outside that does something for your reputation nationally, regionally or nationally, but usually it's nationally. So it depends on what contributions count for what. And even in those environments, publishing is still valuable, even though it might not be required. And so that is a career path. I would say in general, it's tough to expect a whole lot of offload for that because everybody who works clinically is expected to educate in some fashion. And I think that might be getting a little bit tougher. It's better to approach from the notion of you're a clinical educator. And now that's, of course, we all have leadership in our education groups and so forth, but not everybody can be a PD or vice chair of education. And there are a lot more people who want to be than you can have. So at some point, that funnel somewhere in mid-career is going to collapse a little bit, and you all should have a plan if clinical educator is part of your life. Like, what's next? Do you go to the dean's office? Do you focus medical students or whoever the case may be, or specifically in some area, perhaps in the School of Medicine or the hospital or otherwise?
Is it fair to say that if you are someone that wants to go more so of a teaching route and staying involved in academics for that purpose versus research, is it if you're able to get a position as a clerkship director or like you mentioned, a position within the dean's office or PD, are those the primary ways that you would be able to get more of that protected time for clinical education or that you could put forth those efforts towards your next promotion step?
So APD, residency program director, particularly APD, that's perhaps the biggest title I suggest to kind of guard yourself against and know what you're getting yourself into. The notion of you can't work hoping to get more clinical offload. Clinical offload is not a reward per se. Clinical offload is giving you time to do what you need to do that they're giving you clinical offload for. And often that takes a lot more than what the time would have been working clinically. So if you get clinical offload for 12 hours a month, they're expecting about 24 hours worth of work for that thing. So it's a fallacy to think of clinical offload as some kind of gift or reward for doing something. It's offload to do something. And that whatever that something is hard work. And whoever's giving it to you wants to see what you're going to accomplish with that and what you're going to generate with that. So And I also want to give a plug. Research is not a four-letter word, clearly, right? And I see this like, no, not research, because everybody's thinking about organic chemistry and whatnot, and they have these horrific thoughts. So research is about knowledge, growth, innovation, moving the field forward, what's next in the practice horizon. All of that lends itself to an investigation and research. So don't think about the single sort of prove one hypothesis based on a molecule that goes in another molecule that gets eaten by an antibody. Like, these things, that is research. That's just only one very small part of research. I would say the group that's most productive in our department is our operations team. They're cranking out papers all the time on stuff I don't even know what they're doing. So they've really managed to harness how to make other non-classic research things be considered in forwarding the house of medicine, thinking of it that way, bringing it to the next level, the next step, solving the current problems that exist in emergency medicine.
That's a super important point. I, even over the past couple of years, have had conversations with peers and some other medical students a couple years below me who were strongly turned off by academics for the sole purpose of thinking that they were going to have to do
Absolutely.
science research. And even I kind of fell into that initially within the first year or two of medical school and realized that, oh, hey, I can actually develop simulations and do educational research and study learners and create new things within our field through that. And that was a total game changer for how I viewed academia and sort of the next steps in my own career path. So especially for the medical students that are considering one program or another, especially with applications being due soon, know that there's so many other different ways that you can do research and publish outside of sitting at a
Yeah.
bench doing these really complex clinical trials.
Yeah, and I would say, basic science is my personal preference. So I just so you know where I'm coming from. However, and that's why I say though, I mean, really, research has such a negative, visceral tone that I think we have to view it more as like scholarly work, innovation, evolution of emergency medicine and those kind of terms, because I think people are just traumatized. Because often in the first few years of medical school, too, you're being taught by basic science people, professors, and so forth. So that's all you see. You don't see the other cool stuff unless you're involved in, RAMs and other stuff and get to see that. So it's a real bias, I think, that medical students come out, and particularly when pursuing an academic career, thinking, "Oh my God, I don't want that research." There's plenty of innovation, growth, investigation, curiosity, like what you're curious about. That might be it's curiosity, not a research.
Yeah, for sure. We're going to pivot just a little bit now to talk about some advice like for fellowships, for jobs, for things of that nature. This may
Mhm.
be a little bit controversial with the potential change of the residency length from 3 to 4 years, but as it sits now, how do fellowships fit into a career for academic EM? Would you say that they're necessary to get a job now or just helpful?
Like many of my answers, I'll say it depends, and it depends a little bit on what the department needs. And that's also a good question in your interview, is to ask the chair, what does the department need at this point? Because what they need at this point might be something that you can do very well, and it might not be exactly what you're planning on doing, but by doing that, you can grow into what exactly you want to be doing, but what the department needs. And I think fellowships serve a very valuable role. I think fellowships, to be really substantive in what you're doing, should, I'm just going to say it. These are my opinions, not the opinions of all chairs in emergency medicine. I think it's great when they're 2 years because you can actually accomplish some sort of scholarly thing and then be known for something when you graduate from fellowship, because that's the goal, is to be able to have protected time, or if we want to call it clinical offload, to hone something to advance your career forward in a thing. That doesn't mean you have to do a fellowship to get an academic position. But if you come out of your residency and have that thing, or you've had previous training in something else, or you have another degree, or you've had some other experience, that can absolutely substitute for a fellowship. So reasons to do the fellowship is if you still haven't developed your thing and you want to go into academia and you haven't already gotten your thing, or you specifically want to devote the rest of your life kind of studying this one thing and you know that. But I have a lot of people who've been trained in fellowships and then go do something else. They have those skills, they're happy they do those skills, but they end up doing something they didn't need a fellowship for. I do think now at this phase, and fellowships weren't a thing when I trained. Now, if I wanted to go into academics, I would do some sort of fellowship and develop some sort of mini portfolio that I could bring forward as evidence that I could do whatever that thing was, regardless of the length of program. And your career is going to be super long. It's a long, wonderful time. It's not a race. I know there are some important monetary situations. However, you will be well compensated when you finally graduate and go wherever you're going. It's as long as you don't buy a ginormous house and a bunch of sports cars, you'll be able to pay off these loans. I know it's not easy. It is not easy. However, this is not a race. A year, 2, 3, trying to find what you truly love to do and that sustains you and doesn't keep you awake at night and thinking you're miserable is so important. The time is just trivial. It goes so fast. So going to a residency, going to a location, doing a fellowship, doing something extra, getting an MBA afterwards or whatever is so worth it for your future, like happiness in life. And try not to think of it so much as a race to get to a paycheck. And I certainly know that there are challenges and limitations to that, but try to think of yourself as a longitudinal human for the next, 30, 40 years or whatever you decide to do and how you want to contribute.
And following up on that point, do you think that whether a fellowship is ACGME accredited or not plays any role in getting that academic job or getting the opportunity?
No, I don't think it matters. I mean, the ACGME versus not ACGME is largely an administrative distinction. And it does have important complications in terms of who you work for and how you're compensated and all that. And it's pretty complicated depending on the institution. But largely, if you think of fellowship as the thing that you're honing to do, and more likely, if you're pretty committed that you want to do that thing, whatever it is, for forever and ever. Once again, I caution you against that because oftentimes you just don't know. I mean, emergency medicine has changed so much in the last 10 years. Oh my gosh. And it continues to morph. And I actually think it might morph into 2 different specialties. I don't know. It's going to be strange. Things are going to happen. So keep the doors open, keep yourself a little bit flexible. Now, that's not to say you do an ultrasound fellowship and you don't become medical director or vice chair or whatever. It kind of slots you, sort of casts you into a particular realm, and you have to be willing to accept that casting.
Makes sense. For the residents who are finishing up their final year right now, what advice would you have for how they can stand out when they're applying for academic jobs?
Okay, so I'm going to tell you something you don't want to hear, and I'm allowing a pregnant pause for that. Your job is to convince them that you are going to work your butt off, not cause any problems, and that you want to be a contributor to the department. Work your butt off, not cause any problems, and contribute to the department. Almost regardless of what else you want to do. Because administrators in a department spend a ton of time with people who don't fit into those categories. And your job is like, I am coming here to knock it out of the park. Whatever the department needs, I want to contribute. I have skills in this, and I'd be great at this job. And just be super enthusiastic and don't ask about clinical off-road. It's just my guess, just my warning. And be enthusiastic about getting into the weeds, getting into, on the ground level and contributing to the great field of emergency medicine.
I think that's also some great advice for med students that are about to start their interviews in another month or two.
That's good advice for life.
For sure. And you've already touched on so many components of this already, but are there any other elements that when you're considering an academic contract that you should consider or look out for?
I think it's fair to ask about the salary structure because how that's decided, and I still think we unfortunately have differential salaries for differential groups of people. And I'll say it's not anyone's fault. It's just been the evolution of medicine. and medicine in a lot of ways still hasn't caught up. So, and there are different ways of doing this, and to just be cognizant of what you're walking into. And that doesn't mean like grill the chair on their salary or whatever. I can very confidently say to anyone, our salary is on a table. It's a table based on years in rank. You go your year in rank and what level you are and go across, and that's your salary, regardless if you're, whatever your time, oh no, not your time in rank, but regardless of if you had a previous business outside of residency, regardless if, you do research, regardless if you do clinical educator, whatever, it's same thing for everybody at that same level. But other departments have different salary structures, and also some institutions tell the departments what the salary needs to be, and the department doesn't have any choice. So the notion of negotiating a salary is, I think that's going to be less and less possible, because particularly in this financial environment, it's going to be like, this is it. Now, your opportunities for bonus or incentive comp might be a place to negotiate or talk about, because some institutions give like $100 gift certificate as a bonus, and some institutions have 20% of your total salary as possible bonus opportunity. So there's a real disparate part for the incentive compensation.
Gotcha. And I'll ask you one final question before we go to any questions from the audience here. You are obviously a very prominent leader in academic emergency medicine, and I would just love to hear what you personally have found to be the most rewarding part about being in that leadership role.
Well, first of all, thank you. I don't feel of as myself in that way, but I love faculty development and resident career development. It's the best thing I do. So thank you once again for asking me to do this. There is nothing better than to go to the annual meeting and see my people, and even some people who were my residents who are now as chairs. That's telling you how old I am. My residents when I was PD are now chairs across the country. That, you know, helping somebody understand like the future, what are good options, how to get there, how to encourage people, how to work with the different permutations and wonderful skills we have in emergency medicine. We are like the only specialty left that sees undifferentiated, unscheduled care patients. Like the only one left. And we're the only ones who feel okay assuming some risk, because we assume risk every day with every single patient. Can they go home? Can they not? Do they get antibiotics? Do they not? All this happens all the time. And that diversity of knowledge and that ability to take risks when they're necessary is very valuable to the House of Medicine, administratively, and leadership, and so forth. So I completely went off topic. I just wanted to talk about how amazing emergency medicine was, and how those skills can go forth in many other directions if you choose for them to go into.
Awesome. Well, thank you so much for having this discussion with me, answering some really high yield questions that I know some other listeners have been wanting to know. At this time, I'll kind of open it up to anyone in the audience if you have questions, comments.
Do you have any canned questions there, Mel, or do you want me to expound on something random? Or if there's something else you want me to touch up on from the previous stuff?
You're happy if you want to expand on something, or if there's anything else that we haven't covered that you would find high yield, I'm sure everyone would be interested in hearing.
Now, maybe I can emphasize the notion of this second tier thing. I know it's really hard to think about it in that way, but think about, you're making a decision for your life's career. Like you can't switch. I mean, very few people switch residencies in between and so forth, and that's a very small minority. But it's tough if you realize your second year in emergency medicine, like this isn't what you're cut out for. So I hope all of you particularly the students on here, do your due diligence in finding out what emergency medicine truly is. And so it's really important to start thinking about like, what other things do you enjoy? And I had to do some like deep soul searching on this one. Eventually I was like, I just like making things better. So I just want to be in a position to make things better, more efficient, happier, more effective, whatever. And that's where I sort of started. And I knew later in life I needed MBA training to be able to do some of those things. So I went back at the age of 45 to go get an MBA, which was admittedly painful, but I knew I needed those skills. So the notion of starting to think ahead for that, I think will prime you so much better from the beginning if you're thinking about your career, as opposed it's really easy to just think residency is my next step and that's it. It is your next step, but that's not it.
Great. We have a couple of questions in the chat. One from Carlisle Topping. Was wondering if you could talk more about your path to chair and if that was something you always wanted to do, or more broadly, your path to academic EM.
So, brief history. I did my residency at University of Cincinnati. I was offered the APD position immediately out of residency, and I took it and just put my heart and soul into that thing. A couple of years later, as program director, and put my heart and soul in that thing. But my human body, my human brain, really wanted to do basic science research. So after that, after 10 years of doing that residency leadership, I went back to basically trying to write grants and do basic science research, and finally was successful. It took me a while, but it was painful. And I will say, I think I was picked to be APD because I was a good chief resident and I could do the schedule well, and people seemed relatively okay with how I handled things, but it wasn't necessarily what I really wanted to do. But I was so impressed with the title. I was like, oh my God, I get to be APD right out of residency. I'm so psyched about that. I'm so important. Look at me. And then realizing, but wait, Andra, that's not what you necessarily really want to do. So what are you thinking about? But nonetheless, that was my path. I was education vice chair while I was doing the research, and then got involved with some technology development, went to UT Southwestern, had a grand time. It was a lovely place. I was vice chair of business development and faculty development, and also working with the Office for Technology Development. And then chair jobs opened up, and I was fortunate enough to get this one. It wasn't part of my plan, though. It really wasn't part of my plan, but I'll tell you, there's sometimes when like my particular thing is making a difference, working on things, fixing things, making things better, that I could potentially do this in a really great way. And Stanford wasn't all that well known as a residency program or even as a department, 10 years ago, but I've really enjoyed bringing it to where it is today.
Carla, I hope that answers your question. We have another one here too for you. Can you share with the group some of the trouble spots that she might imagine having with new faculty to help those have more successful transitions?
Wow. So I would say, I think the biggest thing is to understand that this is, or even residency, is like a real job. It's not, and to understand that now you have entered an agreement that you will do certain things and they will send you a paycheck or direct deposit or whatever. And if you don't do those things, you might not have a job. And so really annoying things like doing those online hospital trainings and OSHA and HIPAA and all the gazillion things and all that, and signing your charts and, being nice to people and not biting the nurses or screaming or losing your temper or making sure you take good care of patients. All of that is important for your actual job. So just embracing that responsibility and knowing you have to be a professional and address those things. And now you have certain responsibilities in anything, community or academic practice. They will want you to do some basic amount of expectations. And in residency, there's a lot of support for that. Your APD will call you or send you an email or give you a tap on the shoulder and give it to you 3 times before you do it and so forth. When you're faculty or in practice, that doesn't happen anymore. No one's there helping you get your training done and, giving excuses to the office for you that you had too many night shifts and wherever. You just have to get it done. So, and a good starting faculty member doesn't raise a problem in that initial period. They get their stuff done, they submit what they need to submit, and they don't blip on the radar screen as somebody who's going to cause problems. So it's a very simple thing. You'll know what you need to do. Just do it.
All right, great. A couple other questions from Cordelia. 2 questions. You mentioned EM changing to 2 paths in the future. Can you speak more to this? And what are your thoughts on the Masters of Health Administration versus MBA?
Let's see. So I'll do it backwards and I might need you to rephrase the question. So it's very interesting, this Masters of Health Administration versus MBA. And I would say the Masters of Health Administration seems like a very good option if you're absolutely convinced you're going to stay in health. Whereas a Master's of Business Administration might give you some additional options or skills in regard to, forming your own business or working in a different environment like tech or pharmaceuticals or, a teaching firm or like a in billing and coding, and that also has a bad connotation, but that's how the world works. Or if you're exploring some of those other opportunities, I view Master of Health as sort of somebody who wants to be involved in the C-suite of the hospital. And, they're kind of, that's a finite number of jobs too, right? You have a CEO, a CMO, a COO, maybe a CWO for wellness, and there's always some other O's that are in there, but there's only so many of them, and you have everybody competing for them. So I view them as really contingent upon what you view and what you're really craving for in that next career step.
And then Cordelia, with regards to the first question that you asked, I know we touched upon some potential changes with the ACGME in terms of switching the residency length from 3 to 4 years, and that's all currently in the works right now and being reviewed. Is that what you were referring to, or is there another
Kind
question?
of. If you think about it, what happens in medicine now? So in internal medicine, surgery, or whatever, they go through their training and then they make a decision one way or the other. And all folks who are in academics do some additional training or research or whatever. I mean, all surgical residents generally have a year of research training, whether they want it or not, because they're preparing everybody for potential academics by doing that. And so, what I see breaking out, and this is just my theory, and I see it happening in 10 to 20 years, is that you will have people who select the 3 year programs or basic 4 year programs and then serve as true generalist emergency physicians in the community in an important role in the community. Taking care of patients is what we ultimately need to do, wherever they are, whatever they are, and so forth, and in the rural community and so forth. Then I see a separate maybe group developing where residencies are 4+ I'm considering opening up a 5 year residency program more towards academics, so it's the notion that I think will sort of be the difference between a general internal medicine person and then a cardiologist, a nephrologist, or endocrinologist, if that makes any sense.
Gotcha. Cordelia, I hope that answers your questions. And then I think we have time for just one more from Adam. Beyond research, what's the added value of having a true EM department at a university versus just an affiliated residency program?
So all these questions have been great. That's very interesting. I think it depends on what you're thinking you want to do. So the affiliate programs are not going to have as much exposure on the bleeding cutting edge engagement with trainees of different specialties, collaboration with other specialties, and so forth. You're going to be emergency medicine trained at a program, working clinically, and so forth. It's going to be a little harder to access some of that university resources and university environment, and I'd say university sort of accent of the thing. And so if you're considering academics, I highly advise you to go to a university-based program.
And with that being said, I know we have like 2 or 3 minutes left. Any last burning questions?
So I want a disclaimer. Much of what I've given you is my opinion based on, whatever 25 years of experience and so forth, and what I feel is super important for emergency medicine. It's still very important for us to advocate for our field. The hardest thing I do every day is continuing to have emergency medicine be at the front of, or even in the hospital's mindset as the major contributor for all their admissions and what they do and what is our role in society. And that we're not just generalist family practitioners or internal medicine or family medicine. That it's really hard. And some of that has to do with the length of training program, I think. So just want to say we still have a national, not just institutional, but national presence where we have to show up and do great work and excel and fight for emergency medicine for the great specialty, rewarding specialty that it is.
Well, thank you so much again for taking the time out of your day to come and do this and
Oh,
answer
it was great. I'm
me
thrilled.
questions. I've definitely learned a lot myself. Thank you to everyone for joining. Again, as I briefly mentioned earlier in the webinar, if you are a resident or a student interested in getting involved, I'll drop my email. And other than that, thank you so much for coming and joining and learning with us.
Absolutely. It was an absolute pleasure. I really appreciate being invited. I hope you all have a great rest of your day and life.